The urinary system is our body's way of getting rid of all the waste products that are being generated by our cells all day long. So every day we create waste, and that waste needs to be gotten rid of by the urinary system itself. It's a relatively simple system in terms of the amount of structures that are involved. And so we have the kidneys themselves, we have the blood supply coming into it. So we have a renal artery, a renal vein. We have a long ureter to get the urine from the kidney down to the bladder, and then store the urine inside the bladder, and then a urethra to eliminate it from the body itself. And so pretty straightforward, pretty easy system, but it does a lot for us. And so essentially its job is to filter out the blood. And so take everything that's inside the blood and filter it and create something from that that has some water in it and all the waste that we need to get rid of from the body itself. That's there. In doing this, the kidneys then help with regulation of many different things inside the blood itself. Everything from the total volume that's there, so how much water is inside there, what's in there as far as the solutes in terms of the contents that's there, so all of the ions that are there, all of the nutrients that are there inside there, adjusting them as it goes along throughout the day, determining whether we're having enough oxygen in the blood, and has, as we discussed in endocrine system, whether it needs to release either erythropoietin or renin, and so to be able to control other blood functions there. From there, if we're drinking a whole bunch and we're getting rid of lots of water that way, and we're well hydrated, we're going to get rid of that excess water and anything else that is in excess as well. So any kind of nutrients that may be there, either macro or micro, if we're unable to reabsorb it, then it's going to be gotten rid of with the waste products as well. And then it simply stores the urine so that we're not urinating all the time. It's going to have a small amount of urine forming inside the kidneys, and then that drains down to the bladder where we can store it for excretion itself. But unlike other places, once it gets to the urine, it stays there and does not change in terms of its concentration or anything. And so what is there as far as the end product goes. So each kidney, we have two of them, is located on the posterior side of the abdomen. And so they are all the way against the posterior abdominal wall, which makes them retroperitoneal. So they lie behind the peritoneum of the abdominal cavity there. They're kind of a reddish brown color. They do have kind of, it almost peels off when you have a kidney, this capsule that surrounds it, and so it almost looks like a skin that's over the kidney itself. It has a concave and a convex side to it. So the kidney itself has this kind of appearance there. And so it has a concave area. This is the hilus. The outer convex portion there gives us two different portions on the inside of the kidney. And so we have a cortex out in the outside, and then we have a medulla on the inside. So we have medullary spaces, and then we have cortical spaces inside there. Each one houses some different structures inside there. And so inside the cortex, this is primarily where we're going to essentially feed blood into the kidneys. And so blood's going to make its way into the kidney and out to the cortex as it makes its way out there. And then in there, we're going to have our beginnings of our nephrons. And so the beginning part of the nephron begins with the glomeruli. And so we have these capsules of the glomerulus there. That's going to then feed down into the medulla, where we have then our renal pyramids. The pyramids, essentially the top of the pyramid. So if we imagine kind of a pyramid here, the top of the pyramid is called the papilla. And then in between subsequent pyramids, we then have the renal columns in between there. All the urine feeds towards the sinus, So the sinus is just before the hilus of the kidney there, and that's where then it's going to exit from the kidney itself. So here we have a kidney. We have our blood flow coming in through the renal artery, makes its way coming into the kidney, and then it's going to split, and we'll talk about that in just a couple of moments, and goes up through those renal columns, makes its way out to the cortex, where we have our little glomeruli connected to nephrons, and then the urine ends up coming out from the pyramid here. It drains into the minor calyx via the renal papilla. And so just the very tip of the pyramid is the papilla itself on those. And then the urine comes down into the calyces, down into the sinus, through the ureter, and then eventually down into the bladder. So quick little process through the kidneys themselves as far as the ability to essentially clear everything from the urine that is, or from the blood that is potentially damaging to the body itself. So we want to make sure that we get rid of all of that. And with that, we'll kind of take a journey through the kidney, through the blood vessels as we make our way into the kidney, and then all the way up to where we're making urine, and then out of the kidney. So we begin this process coming in through the renal artery. And so that renal artery then splits into segmental arteries. And so that's going to split out through there. From the segmental arteries, we then head up and go through interlobar arteries. And so from the interlobar arteries, that's going to take us all the way up out to the cortex. And then at the top of the cortex, we have arcuate arteries. And these arcuate arteries, in a sense, are making an arc. So the arcuate arteries coming along the top of the pyramids there. So we have our arc or our arcuate arteries on those there. From there, we go to kind of a fun word to say, our interlobular. So our interlobular arteries then split up through there. And so now we can start to take a little bit closer look here into the little close-up picture here. So our arcuate artery is coming across the top of the pyramid, and then our interlobular artery is making its way up from there. And so we're extending on up through to the top of the cortex itself. And then these are going to give off little branches that come over to the glomeruli. And so this is going to be our afferent arteriole. And so the afferent arteriole enters into the nephron. From the inside of that nephron, in this glomerulus here, it's going to loop back and forth and back and forth and back and forth. And so it goes back and forth inside there. And then an artery exits as the efferent arteriole. And so the efferent arteriole then comes out through there. That efferent arteriole, we have one coming out on this one over here as well, is then going to move over to a capillary bed that feeds in and around all of these loops. And so these are the capillaries here are all in between all of the tubules. So these are peritubular capillaries, and they're feeding in through there. These longer nephrons, and so this juxtamedullary nephron goes deep down into the medulla. And so it's also going to have, in addition to just the juxtamedullary nephrons, or the peritubular capillaries with those juxtamedullary nephrons, they're going to have these vasa recta. And so these are going to cross across this descending and ascending loop here of the nephron itself as it goes to there. From there, we're then going to head into the veins. And so from here, we're going to move our way back from those capillaries, come back out, and we're going to hit into our, this one shows a little bit better, into our interlobular vein. From the interlobular vein down to the arcuate vein. So now we're running again along the tops of our pyramids again. And so that arcuate vein then comes down, and we have our interlobar vein. The interlobar vein then makes its way into the renal vein. And then we're out of the kidney. And so then from there, from the renal vein, that can then enter in towards the inferior vena cava and make its way back towards the heart. And so we now have our blood flow through the kidney itself. So those nephrons that we were talking about, this is the kind of the functional part of the kidneys themselves. This is where we're getting all of the components of the kidneys filtering processes occurring. And so the nephrons are where we do filtration. Inside the kidneys, we've got millions and millions of nephrons. And so a couple million nephrons inside each one with the capability of doing filtration. And so depending upon what is in the blood at the particular period of time, it's going to filter all of those solutes out and adjust them depending upon how much is there. There are two different millions of nephrons, and we have two types of nephrons. We have cortical nephrons and we have juxtamedullary nephrons. Cortical nephron here is smaller. Its loop here only goes a little ways into the medulla. So it only goes a little bit way down into the medulla, into the pyramid, versus our juxtamedullary nephron. Its loop comes very far down into the pyramid, and so it makes its way almost entirely through the pyramid itself, all the way down towards the papilla that is there. It begins with this little almost berry looking structure, regardless of which one we have, and so either one of them is going to begin with that kind of berry looking structure there. This is our renal corpuscle, or the Bowman's capsule, or the glomerular capsule, or the glomerulus. Lots of different names that it can go by. And so either way, we have this place where we're going to do the initial filtration of water. And so that filtration of the water that's inside our blood is going to be filtered out. And so we're going to take things out. Think about it almost like a coffee filter. And so we put coffee into the coffee filter. We've got the big solutes that are there. We've got the actual coffee grounds. Those hopefully don't make it through the filter, but all of the liquid dissolvable substances do. And essentially that's kind of what the corpuscle does there. That then feeds in from the corpuscle. We go into our proximal convoluted tubule. That proximal convoluted tubule is then going to go down through our loop of Henle. We come back up and go through the distal convoluted tubule, and then that is then going to drain into our collecting duct. And so we're going to move from there into the collecting duct, and that then drains out through the papilla on its way down. So different things are happening in each portion of the nephrons themselves. And so initially here in the glomerulus, we have blood coming in, comes in through the afferent arteriole, goes in through all of our capillaries here, and as it goes back and forth and back and forth, each one of those capillaries is surrounded by what's called a podocyte. So kind of the more orange looking portion that's over those capillaries is a podocyte, and this helps to maintain the degree of filtering that we can do. And so it's going to be like an extra covering over the capillaries themselves. And the filtrate is going to end up out into this capsular space. And that's then going to head towards the proximal convoluted tubule. So it's going to make its way to that proximal convoluted tubule. And the remaining blood is then going to head out the efferent arteriole. Moving into the proximal convoluted tubule, so we're now out the glomerulus, we're into the proximal convoluted tubule. It's going to weave back and forth and back and forth. And this is the first part where essentially you can think of the nephrons as allowing just about everything to get filtered out. So just about everything is going to move through that filter and into the tubules. So now we're going to have to be able to get things back. And so when we say that we allowed everything to go out, essentially it was everything. And so it's hormones, it's nutrients in terms of especially things like glucose, amino acids, fatty acids, electrolytes, vitamins, etc. All of those things have come out of the blood, and now we need to get them back. We don't want to lose everything. And so the majority of all of those substances are going to get pulled back through active reabsorption into the tubules. So it's coming out of the tubule and going back into the capillaries themselves. In addition, it's going to pull a large amount of water. And so we're going to get a huge amount of fluid coming back in these proximal convoluted tubules. That ends up into the extracellular fluid and then ends up into the capillaries as we move down into the loop of Henle. And so our nephron loop, or our loop of Henle here, has two different portions. And so we have essentially a descending limb and then an ascending limb. And so the descending limb is attached to the proximal convoluted tubule and then to the glomerulus. And then the ascending limb is then attached to the distal convoluted tubule. And so different portions there are going to be allowed to happen in each one. In the descending limb, it's going to pull water out. And so water is going to leave that descending limb. And if we pull water out of a solution, that's going to make our concentration go up. And so on the way down, we lose water and our concentration goes up. On the way back up, now the water stays and the solutes get pulled out. And so it becomes very permeable to solutes coming out. The water is going to stay. So now if we pull the solutes out, our concentration is going to go down. And so our concentration then starts to fall. And so we're increasing concentration on the descending loop. So it's concentrating as we go down. And then on the way back up, it becomes less concentrated again. And so we're changing that concentration as we go through the system itself. From there, the loop of Henle itself has kind of two different portions to it. It has a thick and a thin portion, and those thin portions are still permeable to water, regardless of whether we're on the ascending or the descending limbs. After we move through the loops, we come to the distal convoluted tubule, and in a sense, this is kind of the last chance that we have to a certain extent. This is our last place where we can do reabsorption of the solutes that had been filtered out initially. And so this is going to allow us to change concentrations in this area that's here. And so the most part in terms of what we're going to do here is deal with ions. And so we're going to be dealing with sodium, potassium, and then water. And so we have the ability to work around those processes there. The majority of the other substances we're done with. We pulled it all out in that proximal convoluted tubule, going back up the ascending loop, and we're done. And we're not going to reabsorb anything else here other than the ions and the water at this point. And this is where in the past we've talked about, again, aldosterone and ADH, or antidiuretic hormone, in the process of changing the levels found within the blood of our ions once again. And more importantly, that of water. And so depending upon whether we keep ions or lose ions is going to dictate whether we keep water or lose water. And so aldosterone is going to cause an increased absorption of sodium, and where sodium goes, water is going to follow. So we're going to reabsorb water, we're going to reabsorb sodium, but we are going to lose potassium in the process. Antidiuretic hormone, again, is going to cause the reabsorption of water, And so this is going to increase the amount of water and the amount of sodium and the amount of volume that's inside the blood, thereby for both aldosterone and antidiuretic hormone, increasing our blood pressure. From the distal convoluted tubule, we move into the collecting tubules and the collecting ducts. And so when we get up to that distal convoluted tubule, our overall concentration is about half that of what we have in the blood. And so we have a relatively low concentration of urine at this point. And if you're well hydrated, then all of that urine is essentially going to just leave the kidneys at that point. And so they're going to move from the collecting tubules to the collecting ducts and out through the papillae to the calyces, to the renal pelvis, and then down to the ureters. Once it enters into the calyces, concentration changes are done. We can't change it at that point. If we're dehydrated, though, as we move into those collecting tubules and collecting ducts, we can start to pull back in water. And so we can start to make it a concentrated urine as this process goes. And so that's going to make those processes occur at that point. And this is where, again, things like ADH comes into play. And so this allows us to change that permeability to water or make it less permeable to water, depending upon our release of ADH at that point. So not only do we do reabsorption, but we also do secretion. And so the cells that are along the portions of our tubules are designed to be able to, in a sense, do just that, a little bit of reabsorption and some secretion as well, because we want to make sure that the substances that we need to get rid of are in that urine, so that we get rid of all of our nitrogenous wastes at that point. And so we can see the differences in terms of the cells as well. And so the proximal convoluted tubule was all about reabsorption. And so we're pulling back in all kinds of solutes. And so the cells themselves have lots of microvilli. Increased surface area, increase the ability to reabsorb nutrients. Versus the distal convoluted tubule, they have relatively few microvilli. We're not doing a whole lot of reabsorption here. We're only talking about sodium and water at that point. So once the urine has exited the kidney, it's going to move down from the ureters, or from the kidney through the ureters down to the bladder. And the ureters themselves are really just a big tube. And so think of like digestive tract. This is similar to that of the esophagus. It's a way to get the urine from the kidney down to the bladder, so from the upper part of the abdomen all the way down to the lower part of the pelvis. And so relatively long tubes, some 25 centimeters in length. Again, just like the kidneys, they are retroperitoneal. And so they come down into the pelvis and attach into the bladder. So they make their way down, come into the bladder itself. As that urine is traveling through the ureters, the smooth muscle that is inside of them does contract, and so there are peristaltic waves, which is part of the reason why if somebody has a kidney stone inside there, it's going to cause waves of pain as it's trying to push it through those ureters themselves. Once inside the bladder, essentially it's done. The urine is just going to stay there, and it's going to stay inside the urinary bladder for a period of time until the bladder has expanded enough to cause a reflex that allows for urination to occur. So it's just a reservoir. We're not going to change the urine at this point. We're not going to change the amount of or concentration or anything inside there. Anatomically, between males and females, the urinary bladder is slightly differently positioned between the two. And so for females, essentially the uterus is going to kind of sit on top of the bladder. And so the urinary bladder itself in a female is essentially between the pubic bone and that of the vaginal canal, as well as the uterus. And so the bladder kind of sits in here, and then the vaginal canal comes up, and then the uterus kind of sits on top of it. And then behind there you have the rectum at that point there. For males, you simply have the urinary bladder and then the rectum, and that's essentially it. The only other additional structure that is, in a sense, in there is the prostate gland, and we'll talk about that more during the reproductive system. So here we have our urinary bladder. It has the ureters coming down to it at that point there. Inside the urinary bladder, there is this triangular section here called the trigone. And so the trigone is kind of in an embedded structure. It's immovable. It doesn't move around. It doesn't expand. It doesn't contract. Because the rest of the urinary bladder, all of the epithelium that is there is transitional epithelium. So just like the ureters have transitional epithelium in it, so does the majority of the urinary bladder, and that transitional epithelium is going to allow it to kind of stretch out a little bit. And so as the bladder expands, it's going to stretch a little bit on the inside. Similar to other areas of the body, we do have different layers to the bladder itself, or tunics. The outermost portion is the adventitia. We then have a muscular layer, so we have smooth muscle once again on there. We then have a submucosa, and then the mucosa, the transitional epithelium that sits on the innermost aspect there. The urethra is now our way to get the bladder out of the urine out of the bladder and out of the body. It's going to be similar to that of the ureters in a sense, that it is a muscular tube. So we have a fibrous and muscular tube, and it connects the urinary bladder to the outside world. And so inside there, we again have different layers as well. And so there's going to be a little bit of smooth muscle. We're going to have a mucosal membrane that is there, produces a little bit of mucus. So we have mucin producing cells that are there, and that's going to help to protect that layer of tissues that are there. Smooth muscle fibers help to force and propel the urine out of the urethra itself, and then it's out of the body, and it's gone from that point. In order to ensure that urination only occurs when, in a sense, we want it to, we have two sphincters, and so there are two urethral sphincters. This is going to sound familiar to that of digestion, because we have control over one set of sphincter and we lack control over the other. So our internal sphincter is involuntary. The external sphincter is voluntary. And so we have control over both of the external sphincter in both urination and defecation. So that internal sphincter and external sphincter is going to work together to keep urine in until we're ready to go and urinate. In males versus females, again, we have a little bit of a difference in the urethra itself, primarily being the length. And so with the female urethra, it is relatively short, and so only a few centimeters long, and then it opens to the outside of the body. And so this creates the potential for problems because of that short length. There's the potential that bacteria can start to migrate from the urethra into the bladder. And so this is part of the reason why in females, urinary tract infections are much more prevalent than they are in males. And so in males, we go from a maximum, in a sense, of about 5 centimeters to a maximum of about 20 centimeters in terms of the length. And so we've quadrupled the amount of length that we have between males and females. And so that urethra spans this big, long length. And so any bacteria that's potentially growing and migrating in is going to be flushed out by urine before it has a chance to make its way into the urinary bladder. And so more often than not, it's going to get flushed out of there before it has a chance to cause any kind of problems in the male urinary system. For the male, though, The urethra is then divided up into sections. And so it has the prostatic urethra, the membranous urethra, and then the longest portion, the spongy urethra. So the prostatic urethra goes through the prostate gland, and so it's making its way through the prostate gland itself. It then goes through the urogenital diaphragm. We have the membranous urethra, and then the spongy urethra goes through the portion of the penile tissue, the corpora spongiosum, that is there. For urination to occur, we have micturition this time. And so micturition, similar to that of defecation, is a reflex. And so this is a process that is needed to allow for the bladder to fill before urination occurs. And so it's going to involve, once again, those internal and external sphincters, as well as the muscles of the bladder and the urethra. The process itself is controlled by both the parasympathetic and sympathetic nerve fibers. So the bladder is innervated by both of them. As we get urine filling into the bladder itself, that's going to send signals from the bladder. Redraw that. So we have the bladder here, and those nerve signals coming up from the bladder head to the spinal cord, and then send signals back to the internal and external sphincters. Those internal and external sphincters then are controlled and send signals down. And so as those signals come down, one to the internal sphincter, one to the external sphincter, and if we are not potty trained, then both of those are going to relax and open up, and urine can then flow from the bladder and out of the body. If we are potty trained, then we're going to keep that external sphincter closed and allow for the urine to leave the body itself from there. The pressure inside there is generally controlled by simply the increased pressure or stretch that has been put on the bladder itself, but the abdominal muscles can force that urine out, but definitely want to make sure that that doesn't happen too forcefully, as that could potentially damage the urethra itself. And so now we've gotten rid of all of the potential harmful substances out of the blood and kept what we needed to get back. And we've gotten rid of all that nitrogenous waste.